Okay, thank you to those who are joining us, both in person and on the phone. I'm just making sure, yeah, here we go. All right, we've got slides rolling now. Thank you all for coming. Tomorrow's actually National Overdose Awareness Day, so here we are coming together, trying to do something to address the things the aspects of that problem that we can, and we're hopeful about moving forward and improving Colorado's system of care for those with substance use disorders. So today we're talking about the 1115 waiver and the overall coverage of services that we're introducing in 2020. As we get started.
Oh, Kelly, how do you advance the slides? Okay, try now.
Okay, great, thank you. Yes. Okay, so you'll see our mission there, improving healthcare access outcomes for the people that we serve while demonstrating sound stewardship of financial resources. These are certainly the things that guided the introduction of these services and the building of the waiver. Today, we'll go over a bit of the background that led to the development of the waiver. We'll talk about what's in the waiver application, and then we'll invite comment from you all, those on the phone, on the chat, and also in the room. And we'll talk about what next steps will be taking place for us to move forward with the opening of the benefits and approval from CMS of the waiver itself. Just reminders, if you will, please silence your cell phones. When you're speaking, please share your unique perspective. So we hope to have stakeholders from a variety of settings and regions, and we'd love to hear your own experiences and concerns or thoughts or comments about the waiver. So please share those. Please honor the public space, and as you comment, please state your name first so that all participants live and on the phone can be aware of who is speaking. And if you have comments that you were unable to make during this time, then please write those down and provide us with them so that we can include those in our record of public comment. Okay, so background on the waiver and how we ended up here today. House Bill 1136 passed in 2018, which authorized the state to pursue federal authority to open up coverage for both residential and inpatient services for substance use disorders, and also to expand the withdrawal management services that Medicaid currently covers. We had correspondence with CMS, the Centers for Medicaid and Medicare and Medicaid Services, to determine what the appropriate authority is for those services, and those conversations led to the development of an 1115 waiver to cover those services and institutes for mental disease. Once approved, we'll use both state plan authority and 1115 waiver authority to introduce the coverage for these services. So in general, 1115 waivers are opportunities that CMS provides for states to test new approaches, whether it is an approach to a change in the delivery system, or whether it is the introduction of new covered benefits or eligibility. There are many things that a state could pursue 1115 waiver authority for. There is a special initiative, however, that is the substance use disorder 1115 waiver, and the federal government has provided specific guidance that came out in 2015 and was revised, and new guidance was issued in 2017 for these SUD-specific treatment services. So states are requesting waiver authority for a variety of things. Most states are introducing, as part of their 1115 waivers, the introduction of coverage for residential and inpatient services and IMDs. 24 states have received approval, and there are 4 that are pending at this point. Okay. So the goal of our waiver, as stated in the application itself, is to complete the continuum of care for Coloradoans for substance use disorder services, as we cover in Medicaid, in order to improve health outcomes, promote long-term recovery, and reduce overdose deaths. The objectives that will lead us there to increase access to the necessary levels of care, including withdrawal management, ensure that members receive a comprehensive assessment and are placed in the appropriate level of care, align the state substance use disorder treatment system with a nationally recognized specific SUD specific standard, and I'll talk about this in a moment, but ASAM, as it is consistent with the OBH requirements and licensure, is the standard that we're utilizing. Increase provider capacity where needed, I'll talk about that a bit later as well, and improve the availability of medication-assisted treatment to promote long-term recovery. Okay, so now I'm starting to cover the elements of the waiver itself. So what's in the waiver application? What are we communicating to CMS that we would like to build? So our waiver services, so those services, both actually through the waiver and the state plan, will be open to all Medicaid eligible members. So anyone that has full Medicaid eligibility will be able to access these services. Requires an eligible SUD diagnosis, and with all Medicaid services, of course, medical necessity as well has to be established. There are no enrollment limits, and we will be implementing statewide. Some states have introduced the benefits in regions because of problems with access. We're opening the benefits statewide, understanding that there are gaps in access throughout the state in terms of the number of beds that are available in some facilities or the availability of other levels of care such as IOP. We will be addressing those in our implementation plan along the way, but the benefit will be available in all rays across the state at the same time. So the services that we are proposing coverage for are defined by ASAM level. As I mentioned before, we'll be utilizing ASAM as the national, or the standard of care. So ASAM level 3.1 will be covered, 3.3, which is the population-specific services, 3.5, 3.7, and 3.7 withdrawal management. And you can see the slides. The titles for those levels are listed there. The state currently covers early intervention, and outpatient services, IOP services. We cover level 3.2 withdrawal management, which is a social detox model, and we cover some recovery support services as well. We also cover MAT, but these are the services that we are proposing to introduce with this new expanded coverage. The delivery system will be, these services will be offered through the RAYs, so they will fall under the capitated behavioral health system. The RAYs will manage the utilization management of the services. The costs will be built into the capitated payment rate. As with all services under the capitation, there will be no cost sharing. And the RAY responsibilities will include administering recovery services, utilization management, care coordination, and critical piece to ensure that treatment gains from one level of care are maintained, and transition support. So the waiver application requires that we address financing and budget neutrality. What that means in the requirements around budget neutrality are that the services provided in the demonstration cannot cost more to the federal government than they would absent the waiver. The anticipated cost offsets are reduction in emergency department visits and reduction in repeated inpatient hospitalization. So if we have people in the right level of care, they receive effective treatment, they're less likely to go through repeated hospitalizations and utilize the emergency department on a frequent basis. So we've had a number of stakeholder meetings up to this point. We had one in May really to discuss some of the implementation issues related to the waiver. We also had a series of stakeholder meetings in three parts of the state in June to talk and elicit feedback from stakeholders on the waiver and the benefits that we were opening. And now we have the public comment period that we're in now. So public comment opened on Sunday, August 26th, and will run through the 27th of September. We have 2 in-person meetings today here in Denver, and then Friday, September 6th in Grand Junction. The waiver application is available online, and that announcement was made through the Colorado Register and also through our website, and we sent an email out to stakeholders. So we are eliciting feedback and comments through September 27th, so those can be voiced today. They can also be submitted online, and they can also be mailed in a letter to us in hard copy. So beyond this point, we are planning on submitting the waiver in early October. So that'll mean the public comment period will close end of September. We'll look at the comments that we've received, we'll review them. We will actually write responses to all of the comments. Those get included in the waiver application. And then we'll also determine whether or not we need to address some of those concerns and make changes to the content of the waiver application. Then we'll finalize the waiver and submit to CMS in early October. That begins a 30-day federal comment period. The waiver will be posted again on the Federal Register. And not only will you see what's in our current waiver that's posted, but you'll also see the comments on our responses there as well. Then we conduct waiver negotiations with CMS, which we anticipate always takes a number of months. So we'll be negotiating pieces of the coverage of services and budget neutrality that we discussed further. We've already had conversations about both of those things, including the authorities, as I mentioned before, but those negotiations continue, and the special terms and conditions that will sort of become, that will define the waiver services will be written in that process of negotiation is finalized. After we submit the waiver, and actually already we've begun work on the implementation plan, and as I presented in May, there's a number of pieces that are aspects of the implementation plan. One is capacity building. We've already begun assessment, and we're utilizing the information that's already been gathered in a number of reports, state reports that look at the availability of services not only in residential and inpatient, but also the other levels of care. So we're looking at the landscape to determine what's available and what the capacity is in terms of numbers at each level of care. And we'll be building a plan with state partners and stakeholders to address the gaps in our treatment network for substance use disorders. Our plan is to go live with the services, so to open coverage for those benefits in summer of 2020. Okay, I mentioned capacity building. We're also in the process right now of developing billing methodologies for the facilities that will be billing for these services. We also may need to initiate rule changes. That will happen. Those will go for public comment as well. We also are beginning to plan training that may be needed and support that will be needed for providers, both in the RAIs, the provider level, and also potentially the MSOs as well, because they will assist with an aspect, room and board specifically, of the services. Some of the things that we're aware of that we'd like to provide support and training on, including review and for some, maybe new ASAM criteria will be a focus. Also just the logistics and mechanics of billing so that everyone's on the same page and have a sense of how to move forward when the benefits open. We're also going to be doing a number of stakeholder meetings, series really of stakeholder meetings about implementation, so we'll be involving state partners as we move forward a great deal in that process. We also will be revising the RAI contracts, and we'll be working with a third-party evaluator, which is a requirement by CMS that we have a full extensive evaluation that a third-party entity conducts. So I mentioned some of the support that we'll be providing to RAIs and the treatment community, and those pieces are there. So addressing gaps in coverage of the availability of treatment throughout the state, and then also training on ASAM and other issues that folks will need support on. And I mentioned these meetings. for implementation. We also will continue our monthly newsletters that you receive from Shingo and I, and periodic updates on the website will continue to occur as well. Those may become more frequent as things start to pick up with implementation. Okay, so those are the elements of the waiver. So we're going to open up for public comment. We have comments in the room we'll start with, and then we'll switch back and forth. We have a number of people on the chat, and we also have some folks on the phone. So we'll start with question in the room, and if you'll state your name first.
Sure. Actually, sorry, before we begin taking comments and questions, I just have a couple of housekeeping notes, if I can just kind of review them real quickly. Please be advised that today's webinar, including all audio and your comments and questions, are being recorded. We ask that you please identify yourself and your organization or affiliation before you present your comments or questions. For those of you who are present in the room with us, please use the podium and microphones in the back. If you are joining us online, please enter your full name and phone number in the pod called Public Comment Sign Up to add yourself to the queue on your screen. You can enter your comment or question in the chat module. When your turn comes up, you will be unmuted and you'll be able to present your comment or question. In the interest of fairness, we will address comments or questions alternately from all participants. We will begin with comments or questions in the room first, then we will switch to online participants, and then back to the room and so forth. Any comment or question we receive at today's public hearing and at next week's public hearing in Grand Junction will be recorded. The comments will be incorporated into the demonstration waiver application along with the state's response to said comment or question, and for the purposes of transparency requirements concerning the federal government's public notice period. Following the conclusion of the webinar, the department will post the presentation slides and webinar recording on the department's Ensuring a Full Continuum of SUD Benefits website. And that's all I had.
Great.
Thank you very much.
Thank you, Shingo.
Great.
Okay, Brett.
Do I need to go to the podium?
Please.
Or this isn't,
I think we're fine,
is
actually.
this good?
Kelly?
Kelly said it was okay.
Oh, okay, then that's fine.
Yeah, we're
Brett.
small enough group that, yes, that's fine to state your spot.
Brad Shostrom, I'm with West Pines. I'm also the current president of the Colorado Providers Association. So I have some questions about the projected budget and specifically how you came up with it, because the initial, if my memory serves me right, when the legislature ran the numbers, it was probably about 10 times or 20 times this, is closer to 90 million.
So the CHI estimates were 180 million, I believe. Yes.
Double of what I said. Yeah.
Significantly lower. You're right. It's around 90 million. Our estimate is. So the first thing to note about the disparity between those is that those are not apples to apples comparisons. These estimates don't include services for adults over 65 or children, and that's because that's how we build it for CMS's waiver purposes. The other thing is that these estimates are built off of extrapolations from other states. So we took all of the available data from inside of our state on utilization and cost. We also looked at the available data from surrounding states that was available to us. We adjusted other states' utilization and rates based on our population and our understanding of the utilization, the likely utilization here. We are continuing to make those refinements. One of the things that is always true when 1115 waivers are submitted is that the budget neutrality calculations are offered to CMS and they get refined a lot over time. So we will continue to make adjustments. The other thing to note about the CHI estimate specifically that fed into the fiscal note is that we've spoken with the group that did those estimates, and those estimates are a better reflection of the anticipated need. However, we don't anticipate that the capacity will be there in the first year to have the utilization that was assumed in that particular estimate. So those are the differences that we know. We know that our estimates will change and will go up as we refine these. But I think the first thing to note is really it's an apples to oranges comparison.
So just to make sure we're on the same page, literally. So page 23, you're estimating that the expansion will be 4.7 million for all of these additional services?
So we're estimating a cost of approximately 90 million.
Oh, so what are the numbers on page 23? Pardon my ignorance on this matter.
I'm going to turn this over to John, who's here to answer these kinds of questions. Exactly.
I think that's probably wherein lies the confusion.
Yeah, this,
I don't see 90 million anywhere, but.
Right. Yeah. It's built in, but this is the presentation that CMS is, this is what CMS requires. That 90 million assumption is built into those estimates that you see in the waiver application.
yeah, this is John Doherty, and I work with payment reform, and I've been working with our contractor on these budget neutrality numbers. So yeah, these estimates are what are associated with the waiver authority, which is specific to, like Kim said, members, not children, not elderly, and this is specific to days in IMDs. And that's where we are requesting waiver authority. There's additional cost associated with not with days outside of IMD and the total expansion of residential and inpatient benefits. But this is specific just to those IMD days and those at that age range, 21 to 64.
Thank you, John. We'll be opening up coverage in all facilities, whether there are 16 beds or more. And the CHI estimates were based on coverage of all services. These estimates only include any stays in IMDs, so days 1 on.
So the majority of the expansion dollars actually won't go towards facilities that are currently considered IMDs. Is that what you're saying?
I don't know that we can answer that, but
yeah.
There's no difference in eligibility for payment to those facilities.
Right.
It just depends on the availability and what's in the network.
Yeah. So these numbers are pertaining to those IMDs, not to all the other facilities.
So IMDs for adults 22 to 65.
Yeah.
This is Susan Matthew with the department. I'll take you on a quick little road trip down CMS authorities, and that maybe will help explain kind of what we're working with as well, and then those numbers might make more sense.
Yeah, that'd be great. Thank you.
So the underlying authority for most services is what's called a state plan amendment, or state plan. And so we are working, Kim referenced that, we are working on a SPA, or a state plan amendment, to bring in the inpatient and residential services, the full continuum of ASAM levels that Kim talked about, and we will be operationalizing those services through our behavioral health capitation, as part of the regional accountable entities.
Mm-hmm.
A portion of those new services that are agnostic of provider type, except of course they have to meet licensure and ASAM requirements, are those services that are provided in the Institute for Mental Disease. So our 1115 waiver is granting us the authority to get federal dollars for the IMD services. Yep. So the dollars that are here, as Kim said, are not all of the services. It's just those that are as our best estimate at this time of what utilization is going to look like, what capacity is going to look like for those services in an IMD.
You're also asking for dollars for services outside of IMDs too, right?
That will be part of our state plan amendment that we are also going to be running.
But it's
not included here because technically CMS doesn't want us to.
The waiver only includes the IMD services.
It'll be reflected in the rates for the 1915B3 that you current.
It'll be reflected in the capitation rate.
Correct.
which
Which
is part of the 1915.
Right. Yeah.
Right.
which we're already working on as well with the data that we're using for this purpose also has the purpose of starting to develop our rates.
So one aspect, so then I'll let Daniel. So really, the waivers to get services covered at the Institutes for Mental Disease.
That's it. Because that's where the restriction is. We need a waiver for that.
Yeah.
We can actually provide services in non-IMDs under state plan.
Yeah.
We just haven't had the authority up to this point. So the waiver is really about the IMDs.
Okay, that makes sense. Thank you.
Very good, right?
No, it makes sense. It makes sense.
I just want to check to see if we have any questions online, and Kelly, it doesn't look like we have any right now. So we'll go to another question or comment in the room.
Hi, this is Daniel Darting with Signal Behavioral Health. So I'm just to press on this a little bit more, and I know this the waiver document is sort of a technical thing that shouldn't be interpreted as the state's plan for how to implement residential inpatient and withdrawal management in the state. So knowing that, this is a little bit me just doing math in my head quickly, which is a very dangerous thing on a Friday morning. But the majority of the residential providers that we work with right now would be 16 beds or more. And just to throw a ballpark out there, our total contracted residential services come to just shy of $20 million this year. Mm-hmm. So then, as Signal is covering 3/4 of the state, right? That's a incomplete statistic. So just if I'm interpreting this correctly, it's about between the two populations, the expansion adults and non-expansion adults, it's about 9.5-ish million combined, if I'm adding the 4.6 plus 4.7 in terms of what is covered under this waiver as a part of the IMD. Am I interpreting all those things right? So this table, if I add up the two population groups, it's 4.6 and 4.7, right? So that's, I think, 9.5-ish, 9.4. I'm doing that right. So if that's the case, I'm just saying I'm not sure. I might bias it based on what my sort of, again, in the MSO world information would be that we might have more beds that would be attributed to IMDs than just, again, this. If I'm doing this correct, and John, please tell me all of the ways that I am wrong. I'm totally sure that that's the case.
Well, I think so. You're looking at coverage of a broader population beyond the Medicaid.
Not really.
No.
Not based on what you. Well, okay. So sure. So we usually say your non-Medicaid indigent population ranges between 5 and 15%, depending on sort of what we're looking at. So let's call that 10%. Still it's not a significant drop to me, and the age groups are still in line with, I think, our population observed.
Okay.
Just the comment, I guess.
Yeah, and the other ways that this might be that we didn't go into too much detail on are that as we revise the estimates, they're extrapolations currently of neighboring states that have done this, and in those states they're disproportionately lower cost of living, and so as we revise, we would expect they would be more likely to increase our estimates, but we needed to put out what that is the best.
You got to start somewhere.
And we have adjusted for higher rates of SUD in Colorado compared to the other states, so we have made some of those adjustments already, but like John said, there are more revisions to make.
But I am interpreting this correctly then, that this is, and so did the raise PMPM go up by the amount noted here? Is that what goes into the capitation to cover this?
If we were to assume that that's a good question. And if we were to assume that these are all of the benefit expansion, which it's not, because this is the IMD portion only, then yes, that's what would happen. But there's the state plan portions as well that would increase that. But I think most of the concern is I do think that we need to refine these numbers and
I more than anything else, and I don't mean to be like, wait a minute, right? Like, it's just me trying to understand it too. So I appreciate that. And so you have the state plan amendment, you have the waiver that applies to the IMDs. If I'm hearing too early in the presentation, the cost savings also comes from the other Medicaid benefit dollars, not just those inside of the capitation. Is that correct, or it's all within the capitation in terms of budget neutrality? Again, feel free to ridicule my question.
Currently, some are covered under the cap, some are not.
We're not held to savings
Inside
within the cap. That's not So, yeah, I don't know how well I can explain.
Based on the
that.
poor question that I posed.
No, it's not based on that as a problem. It's just it's difficult to explain. This is, we have to be, we're held to a standard of, this is what we would have spent if we would have had that benefit. And we have to be held to that amount, that projection, projected and trended forward into the future. So there's not, we're not held to recoup savings to make it such that we pay for all these.
So we're opening up like a sizable amount of new services, right? Non-IMDs and IMDs. For the 1115 waiver, we don't have to demonstrate budget neutrality for the non-IMDs. They have a hypothetical model that allows us to assume that we would have already covered that, or we could have been covering that. So we're only demonstrating budget neutrality for the IMD services, is what John's pointing to.
And this is Susan from the department. We are now, I believe that 25 states have approval of 22 and 4 are pending. So in general, budget neutrality is where a lot of the work gets done. Once we've submitted our application, we've already been working with them, but we'll really dig in and they will use, CMS will help use the experience they've had with other states for us to refine our methodology and to assess kind of where we might need to make some changes and adjustments. The goal, obviously, is that we make sure that we've built enough into the waiver that we can cover the cost of the services that we expect they will cost, which usually that's where they work with us to make sure, oh, you've assumed enough, have you looked at this, talked to this other state, and I anticipate that the bulk of our conversations moving forward with them will be about the budget neutrality because the rest of our components are fairly straightforward.
And that's what we've heard from other states experience.
And this includes all of the components, residential, inpatient, and medical withdrawal management in this calculation for the IMD. I mean, it's the whole thing. It's not, it doesn't discriminate by level of care. It's
for all costs for 4 days in which a member would be in an IMD.
Okay. And so those numbers that I gave don't include medical withdrawal management from my side, and it's from an expense standpoint to me like a significantly higher rate, per day, probably in some cases 3 to 4 times what a residential day that we would typically pay in MSO system. So it just helps me to know like what I'm looking at. So thank you. I'm sorry to ask so many questions. I don't know if that was all one question. I feel like one question with several parts. I hope that was okay.
I broke it up into 5 things.
Thank you. Thank you.
I'm just checking to see if we have any questions online. Just a quick reminder to those of us who are joining us online. If you have any questions or comments, please enter your full name and your phone number in the pod called Public Comment Sign Up and add yourself to the queue. And do we have any on the phone? I don't think so. I'll take a look, but... Sir.
If you want me to unmute the line, I can, but that would be the only way that people.
Okay. Yeah, we can go ahead and give those on the phone an opportunity.
Okay, so for those of you who are joining us online or on the phone, we're just going to unmute the phone line for everyone for a few seconds. Please, again, give us your name and your affiliation or your agency name if you do have a question. Kelly, please unmute. Are there any questions on the phone?
All guests have been muted. All guests have been unmuted.
Right, we invite any questions on the phone line now. Okay, going once, going twice. All right, we're just going to unmute we're going to mute everyone again, and just back to the Q&A. Are there any other questions or comments in the room?
Yes.
Sir.
All guests have been muted.
So in terms of the rates for each level of care, are they going to be fixed rates or are they going to be negotiated rates that we would negotiate with the raise?
So at this point, our expectation is that there'll be negotiated rates with the raise. Yeah, and there's an average rate that's being built in, considerations for withdrawal management, rates being different, of course, Daniel. Also, we've considered how to build in an increased cost for co-occurring disorders services, because we know licensure levels, there's more expense associated with offering those. We're also considering the increased expense of services for parenting pregnant mothers. So a variety of things that will influence the average rate, the average unit cost that's built into the capitation rate.
Great. That was the answer I wanted, so thank you.
Glad to hear that. I didn't know.
Correct answer.
Correct answer, yeah. And so if, I'll let Daniel go, since then, yes?
No.
And so what, if any, will there be blended and braided funding from the managed service organizations? So that's, I'm actually asking Daniel's question for him.
And I'll say the same thing that I've said so far, which is, and in other meetings, is that the CMS has restrictions against us covering per diem or room and board.
Okay.
That persists, especially in the 1115 waivers. So we will rely on the block grant dollars coming through the MSOs to pay for room and board to supplement the treatment service payment for the daily rate treatment services that are paid by Medicaid. Operationally, there's a lot of implementation work that will need to occur to figure out how to make that as smooth a process for providers, RAIs, and MSOs.
Yep.
We'll want those players at the table discussing.
And you would do that for every level of care, including withdrawal management?
Correct, except, Susan, I'm going to rely on you for this. Inpatient, we pay room and board, correct?
Yeah, this is Susan.
Inpatient.
Yeah, the hospital setting obviously operates under different federal rules from our federal partners about the per diem and what that covers in the inpatient setting.
So withdrawal management, if it's in a hospital setting, then the room and board would be included in the daily rate. If it's in a non-hospital setting, then it would be separate.
3.7 below.
Correct.
Yeah, and so from if the withdrawal management is in a hospital setting, we would no longer bill it through the physical health benefit, but we would bill it through the RAI? Or would we have the option to still bill it through the physical health benefit, which we're currently doing?
I don't know that that's entirely clear yet, so we're having lots of conversations around billing methodology. Yeah, and certainly this is the time if you want to say a position or make a comment. I don't know that I can answer that conclusively at this point, though.
Yes, yeah, whatever pays us better.
Fair. You're on record.
Well, let the record show.
This is Susan. I will say, and as we're exploring all of this, I'm sure you all have experienced this as well. The residential is a little cleaner. I'm using air quotes because nothing about any of this is super clean. The inpatient side is harder to navigate because of all the different provisions with inpatient hospital settings. So we're still really assessing what we're doing now, what we want to be doing moving forward. We really do, as a policy, we want the RAIs to manage the full continuum of this benefit, not the least of which is we are paying them to do that type of work. It makes the transitions smoother. The waiver requires us to really outline clear continuum of services, clear transition plans, how we're monitoring, and so the more we have that under a system that is doing that work, the better it will function in terms of a lot of different pieces. So that's kind of our operating philosophy, is that we want them to manage this along with all of the other behavioral health benefits that they get.
And they know how to manage a detox benefit.
Right.
Sure. And the only other thing I'd add to what Susan said is that CMS is also really clear about the importance of managing assessment and level of care determinations. That's one of the individual milestones in the implementation plan, so that'll be some of the work. And we're using ASAM criteria, and so there'll be a conversation where both parties are speaking the same language.
Yeah. And just to clarify, the RAIs aren't managing that, but their parent organizations, United and Blue Cross Blue Shield are, so they know what they're doing.
Colorado Access doesn't have a parent organization.
But Colorado Access doesn't have a parent organization, so they are in a different situation.
Thank you.
Thank you. Okay, we actually have a question from one of our online participants. This is from Nancy Vandemark. Nancy's asking, where do the protections for specialized residential for pregnant and parenting women established under HB 19-1193 get addressed? Is it in the state plan, the 1115 waiver, or the 1915B waiver, or some other place?
Thank you, Nancy. So we're in the process of working with CMS to determine whether those protections do need to be built into either the state plan or the waivers. One of the things I can say is that this waiver opportunity will allow us to expand the coverage of those services to IMDs, which is generally thought to improve access and increase the number of beds that may be available for that population. But we are thinking about and working with our Special Connections stakeholders and team here to determine what needs to be considered as we implement. Thank you for that highlight of that special population.
Hi, this is Angie Wold with Arts, and just kind of piggyback on that and to go to some of the other questions about the payment. So I didn't notice in the writing that there's like a limitation on number of days. So are you not going to define that, and it'll just be up to a utilization management review, which I'm hoping then is taking into consideration it's not something we do now, so it's going to be a huge administrative burden for staff, to potentially have to constantly prove medical necessity. So when they fall out of coverage then with Medicaid, I'm assuming if they qualify for like MSO dollars, then they would fall back to that payer. Is that going to be allowable?
So to answer the first question, there is no day limit on these services. They have to have medical necessity to continue to receive the services. We do have to answer to CMS for a 30-day stay target.
Okay.
So that's something that we're responsible for. However, there is no cap on the number of days for these services. We will require reassessments for level of care determinations. Good practice suggests that we want to step people down and that they transition to lower levels of care when it's appropriate. But that should be determined by their fit with the appropriate ASAM level. So we will expect providers, and the RAIs will be responsible for ensuring that providers demonstrate medical necessity and are doing some repeated assessments. We appreciate that there is, as a clinician, having been one myself, I know that it's a hassle to do a treatment plan, but to update those on a continual basis. So we'll consider what's clinically appropriate with regard to those reassessments.
If I could say this, Brad West Pines, it is a change in how some organizations will be operating. It's a managed care model, and there's a higher administrative burden, and there's no guarantee of covered days, and so it's a big change. I mean, I think people should truly recognize that. They'll have to increase their staff. They'll have to increase their utilization review. It's a big burden. And if the RAIs are as meticulous as they currently are, there's a lot of days won't be covered. But I can't speak for them. I can just speak from working with them in other services.
Sure. I mean, and I can appreciate, I think that you're right, Brad, it is a shift from how services are delivered now through block grant dollars, and it'll take some adjustment, and that's part of why we plan to offer that support to providers and RAIs to help clarify the utilization management process, prior authorizations, things like that, to really help providers and RAIs communicate in ways that make it a smoother process on both sides.
As a provider, I mean, what we don't want to see is that, the person's coverage has not been approved going forward, and we have no other way to continue to pay for their service, so they're out on the street. They're not appropriate yet for a lower level of care, but they may not be meeting medical necessity. You said use a unique perspective. I mean, the residential facilities we run, those people are so severe. They're not ready to go in 30 days or 60 days or even 90 days. So it's not appropriate to put them back on the street. And there's obviously complications with legal involvement. So I know that there's been discussions with the Department of Criminal Justice, which I'm interested to hear more about too. But I mean, that is our biggest fear, is that the people that, the state thinks that we're going to be providing help to more people, but might be jeopardizing the help that we're able to provide, good quality of care. They might be kind of getting shortchanged a little bit.
It certainly, the management will look different, and the intention and operationally how it should work is that if someone has medical necessity for a level of care that is residential, then they have access to these benefits. And when they no longer have medical necessity, then they're transitioned to a lower level of care. They are provided with those supports and transition supports as well. I certainly appreciate that in practice, there will be things to work out. I appreciate you bringing this issue to us and certainly record it, and we'll consider it as we operationalize things.
And so the second part of, what was your? Angie's question about, so let's say, patient works down all the levels of care and then the lay determines they don't meet medical necessity. At that point, could the MSOs continue to pay for the treatment? Potentially, if medical.
Residential?
Yeah.
I guess I'm having a hard time imagining if they got all the way down to outpatient, unless they had a relapse, which certainly can occur, and then they would need a higher level of care again. But then if they need a higher level of care and then medical necessity is established, then we continue to be the payer.
Or if they're continuing in residential, but the rate does not want to pay for them any longer because they don't feel like it's medically necessary, but the clinical team believes it is medically necessary, could they then use MSO dollars or block grant dollars to continue their stay?
I don't know that that wouldn't be up to us.
Would those dollars be available? You know what I mean?
I can just add one quick thing. There is an appeal process too. So I think part of that process would be if you engaging with the RAE on whether or not their medical necessity determination, one can always appeal it and then have that conversation. I can't speak to how OVH or the MSOs would manage beyond that.
I don't know what else be allowed to do.
Yeah, so I think some of this is still to be decided.
It's hypothetical at this point, right?
Right.
I'm just speaking from most of my career working with as clinical care with managed care, and it's,
I think
there's limits.
I may be reaching out there a little bit, but right, there are limits, and I can't imagine a situation in which there would be zero disagreement. So what we'd like to do, though, is help providers and the RAEs have the common understanding, give them the tools so that they can have the smoothest process as possible.
Yeah, I think
and really,
levels of care.
ASAM criteria, there's a section in the book on working with managed care, and I think we want to adhere to those principles that are in that book. And that's why we've chosen,
If there's a step-down process,
that's right.
that could hopefully allow a person who needs long-term treatment. How long do you all treat people?
9 to 12 months.
90.
That's what I'm saying. I know they're not going to cover this for 9 to 12 months, and many of them are coming out of prison, and they may not meet medical necessity anyway, so it might be a moot point. But for the women, especially the special connections women that are pregnant, and they come in, a month pregnant, hopefully they would keep them covered until they deliver the baby. But, those are the types of considerations that because our residential facilities don't operate in a managed care model at all. So it is very different for us, and the population we serve is different than, like I said, like a 28 or 30-day facility. So we're trying to figure out where we fit into this, because we talked, in one of the first meetings, maybe we don't fit into it. I don't know. I mean, that's part of us trying to figure that out.
And John, you had a comment a while back. Does it still?
Oh, just to Brad's question about administrative cost, and that's another reason why we're going to build this into the capitation, because then as we move towards actuarially sound rate, the admin is built on top of that.
That makes sense.
Yeah.
Thanks, John.
Okay, I'd like to take a moment to let our online participants ask any questions. Again, please add your name to the public comment pod and give us your name and your phone number so we can unmute you. Any comments from online or questions online? And doesn't look like it. So Kelly, can I also ask you to unmute all phone lines once again, please? We're also inviting people who are joining us just by telephone to also submit your comments and questions. We will unmute the line in just a
All
second.
guests have been muted.
Okay,
All guests have been unmuted.
Right, all guests are unmuted. If there are any questions from the phone line, please give us your question or your comment now. Going once, going twice. Okay, we will mute the phone line once again and bring it back to the room.
And Daniel had a question?
All
Okay.
guests have been muted.
Daniel?
I'll try not to ask a 37-part question again. So Nancy had asked about this a little bit, but I wanted to be sure I understood it, because I know there's just been discussion about the Special Connections Program and whether that sort of gets rolled up into this or whether that's sort of kept separate. And that's a separate waiver right now, if I understand that or remember that correctly, Special Connections Program.
I believe that Special Connections is under the 1915B waiver.
Okay.
For the, again, to further confusing, for the extended stay portion, the 0 to 60 day is part of our state plan.
And then the way that the 1115 waiver will come in is to allow those stays in IMDs. Because currently they aren't allowable in IMDs.
So what we've heard from some special connections providers is that they limit the beds that are in use in order to stay within the non-IMD definition.
There may actually be additional capacity available once that limit is lifted through the authority of the 1115 waiver.
Which could also create some administrative efficiencies for those facilities that are capable of handling maybe 30 and are handling 15 to manage to this federal requirement.
But the plan would be, there's no reason to think otherwise around the length of stays, say, on average exceeding 30 days for that particular program, which already has a waiver associated with it. I mean, that would be a real, I mean, we don't want to see that. I mean, there's no clear, there's no reason that I would think that anything would change around clinical necessity below 30 days for a Special Connections Program, and all those programs have averages well above that. So
They're just, for none of these services, there's just no day limit on any of the services that we're introducing. And, so what we want to confirm is that someone has a need for a particular level of care and that those services are being offered in an effective way and that people make progress and transition to lower levels of care. And that's just what good clinical work looks like. And we know this population is more complicated and has more extensive needs. So it's not unreasonable to assume that those days may be longer. And we know that those services cost more. And that's we're building that assumption into our rates as well.
And on that 30-day average, it's a 30-day average across all populations receiving this service. So it's not like CMS or us would go in and say, for pregnant women, the average was 60 days. For the majority of the population, it's 20 days.
We know we have people in withdrawal management for 3 days or something sometimes. So we'll have some short stays and we'll have some long stays. And so.
That helps.
that was very helpful.
Okay.
Okay, we actually have another question from one of our online participants. So, allow me to read this. Also from Nancy Vandermark. Thank you, Nancy. Will the rates be required to use the ASAM guidance around programs serving parents in their determinations?
So we haven't specifically talked about that population and authorization or we don't have specifics. We've talked about some utilization management issues with that population. I think we need to dig a bit deeper before we can really provide comment on that, but I appreciate the issue being raised, and I think we'll explore if there's any follow-up, Nancy, that you have, any suggestions or any, anything specific that you want us to take into account, please let us know, either now or through the online public comment opportunity.
Thank you very much for that comment. Back to the room. Are there any questions or comments here?
have one question. I'm J.K. Costello from the SUD group. And my understanding is that some of the facilities licenses 3.7 right now throughout the state of health don't provide, maybe, if you already went over this, just tell me that.
Yeah, so we're aware of that.
8SAM, 3.7,
Yep.
like 24-hour nursing.
Right.
What's the plan to?
So we're working with,
that?
the Office of Behavioral Health already on rule revisions. So those have been drafted, and they will begin the public comment process for those. So they're refining the changes that they've made, and we'll post those for public comment, go through the whole process that's required for rule revisions. And the changes that were made were to better align the licensure requirements with ASAM criteria. So that will mean that some facility, and actually I know that work has already been done around the state to, have programs that are licensed at 3.7, but their offerings are consistent with 3.5 to address that and relicense at 3.5 or make changes themselves so that they can be consistent with 3.7. I see another question bubbling up.
Yeah, just to follow up, Frank Cornelia with the Colorado Behavioral Healthcare Council. The rule that you're suggesting, is that the one that was just released, the proposed rule? Is that the one?
No, this one hasn't been released yet.
Okay.
It's just in draft form, as I understand it. Yeah. And it's just, what they did is took the licensure rules and sat down and said, okay, what else is in ASAM that's not reflected here? And so some changes were made, and we'll see what those are when they're released.
Thank you.
Brad again from West Pines and Cova. So the OBH is going to be more stringent on their level of care criteria.
They're going to be more consistent with ASAM, yes.
They're going to be more consistent. So there'll be fewer 3.7s, I suspect, and
until there may be expansion. Yeah,
I mean, and that makes sense because the higher level of care, the more cost associated with it,
and
more reimbursement would go with that.
Right, and there's also an assumption that there are probably far fewer people that actually need true 3.7 level, because if there's people that are being served in these 3.5s adequately now, they probably really need 3.5 rather than 3.7.
Yeah, that makes sense.
You had said the benefit will go live summer of 2020. That's not, the statement is not July 1 of 2020.
We hope for July 1. We're doing everything we can to get the system ready, to get the approvals, the rule changes if necessary. That's our hope. But we're also trying to be sort of nimble and adapt along the way.
Right, and as part of that, just the negotiation process with CMS. So if you don't get it approved by CMS, turns out it can't go live, right?
Right. That's right.
It's pretty hard, yeah.
Yeah, and the 1115 waiver is only prospective, so we cannot go live and draw down. We can go live, we won't get any federal funding for it, so that doesn't seem like a very wise fiscal decision for us. So we would have to have approval in hand prior to implementing and paying for the services.
Is there an over-under on this? All right, I won't make you go.
I will also say, this is Susan from the department, obviously CMS negotiations are a big component of this. We have system changes we need to do. We need to make sure that we have adequately built the rates for our rate partners. We're working on provider capacity. I mean, there are a lot of components to bringing this up and bringing it up correctly and effectively. And so it's always easy is maybe not the right word. We always say federal negotiation because it's very concrete. I think people understand that that is a time-consuming process, but a lot of the pieces of this are also time-consuming and intensive, as you all know, because you've been doing this work for decades in some cases.
Yeah, we're really trying to be as thoughtful about things like billing methodologies and that sort of thing to get it right. We won't get it right. We want to get it at least in the ballpark, and we'll improve over time.
Just a quick check. We invite our online participants and our phone participants to also submit questions and comments. Again, if you're joining us online, please enter your full name and your phone number in the pod called Public Comment Sign Up. And I'm not seeing any online comments at the moment, so we will also unmute all lines again for our phone participants to submit any comments and questions. Kelly, when you're ready.
All guests have been unmuted.
All right, we invite our phone participants to also submit any comments or questions at this moment. Okay, going once, going twice. All right, we will meet the phone lines again and bring it back to the room. Thank you.
All guests have been muted.
You and,
This is J.K. Costello.
yeah, sorry.
That's okay.
Assume that growth will stay the same rate, right? So that there won't be adverse selection where people who are hiding out, who are in need of residential treatment, aren't going to join Medicaid at a disproportionate rate. Have you looked at other states? Does that make sense? Like, you assume a constant growth of Medicaid, whether this waiver is approved or not.
If you're talking about caseload of, like Medicaid caseload, because that's separate, the budget neutrality is based on a per member per month.
Right, so I'm talking about, will there be more members proportionally who want residential care, who say, oh, I can get residential care, I should join Medicaid, who aren't now? Like, have you looked at other states to see if there's that type of adverse selection where people join Medicaid to get inpatient treatment? Because it would throw off, you would have disproportionately many people joining with very high costs to the base.
Right, and this is a population based on utilizers is what defines this population. Utilization defines this population, and that utilization has a high growth rate. So that is factored in because there's people with an SUD diagnosis code are on the rise, but we haven't looked too much at within that yet. So as we move to an actuarially sound rate, we're going to have to dive into those other states' utilization more to refine that.
And so you're suggesting that overall Medicaid enrollments may jump?
I mean, I don't think it's a huge number of people, but they're really high cost people.
Right. Yeah, no, it's interesting.
If you had SUD and you weren't interested in going to your primary care provider, and then you found out that you could go to residential, that might be an incentive for you to join.
Yeah, I wouldn't expect it to be super high, but it'd be interesting to look into.
Yeah, this is Susan. I don't actually know that I think the population you're getting at a little bit is what we call the EDNE, the eligible but not enrolled population. I don't know what our estimate of EDNE is right now in the state. It's fairly low. Because we had such a successful Medicaid expansion, which actually brought in a lot of other individuals who had been eligible to Medicaid prior to the expansion, but with all of the advertising and the work that was done to get that new population enrolled, we picked up a lot of the welcome mat effect, other people who had been eligible in the past. There might be some there, but I'm not sure. I know groups like the Colorado Coalition for the Homeless and some of the advocates for the homeless population had done a lot of work to get individuals enrolled in Medicaid, and similarly with some of our criminal justice partners, we've been working closely with them just in general to get them individuals enrolled in Medicaid prior to release to smooth that transition. So there are certainly, I'm not going to say we have everybody because we certainly don't, but I don't know how much of an impact that would have, but we can look and see whether there's any way to estimate it.
Yeah, the states that we have looked at, that's something we can look at, and so we'll make a note and we will discuss with our contractor.
What other questions?
I'd like to say that I answered one of my earlier questions.
Okay.
And this is that, so for level 4 withdrawal management will still be covered by the medical benefit. So, at least that's what I'm reading. However, 3.7
will fall under the capitated.
Yeah,
system.
that makes sense. That makes sense. So yeah, like a hospital-based or psychiatric-based would be. So, just let the record reflect that, please. Thank you.
John, did you have anything to add on that, or? No? Okay.
I'd like to take a moment to ask our online participants to submit any questions or comments that they might have. And it doesn't look like we have any comments online or questions online, so back to the room. Are there any other comments or questions? Okay.
This is JK from Study Group. In other states, I understand this has been really successful when you pair the benefits with evidence-based care. So things like that, like a lot of detox is residential, they don't do medication-assisted treatment. Are you planning to have kind of a carrot and stick where people will have to provide evidence-based care in order to get reimbursement for inpatient residential services?
Specifically with regard to, this is Kim McConnell, with regard to MAT, CMS requires that MAT be available through any residential or inpatient treatment providers. So someone brought it to my attention yesterday, like how close is that? Is it, someone on staff? Is it someone on contract? Is it someone that comes in, or can they get them out into the community and access a provider there? Like, I really want to think through those questions very clearly. With regard to evidence-based treatment goes beyond MAT, certainly it's an absolutely critical component of what's being offered. But we're also thinking about, what else needs to be part of what a treatment program offers and how it's run with evidence-based interventions as well. So the therapy components and the other pieces that we know to work. So.
Yeah, do they offer alternatives to 12-step groups?
Exactly.
And with MAT, I'm not familiar with the CMS rule. Is it all forms MAT, one?
As I understand it, it is, buprenorphine, naltrexone. So the provider should be offering the array of medications that are known to be effective in supporting people's recovery.
Thanks.
We don't have any questions online. Any other questions or comments in the room?
A question. This is Angie from ARCS again. So earlier you mentioned like you're going to put together like an implementation plan.
Yes.
What this looks like. So will that be better defining like licensure levels of what the facility requires, and that would be made available, I'm assuming, way before this is rolled out?
Yes, Angie, so I can tell you a little bit about kind of the work that's being planned now. So there are 5 milestones, six milestones from CMS. The gist of those is you've got to look at your capacity and access to care at all levels. That's the first one. It requires that we establish a nationally recognized SUD-specific standard. So we've adopted ASAM. Of course, it's consistent with what's already happening with OBH, and that assessments occur that are consistent with that standard, that provider qualifications are consistent with that standard. So that's the work we're doing with OBH on licensure. It requires that we ensure access to, that we do some prevention and intervention for overdose deaths, and that relates to access to MAT, but also work on the PDMP, the Prescription Drug Management Program. We're also going to be demonstrating to CMS the variety of interventions that have been done across the state to change opioid prescribing, the work that the Colorado Consortium has done. And then finally, the last milestone has to do with transitions and care coordination. As many of you know, 1287 speaks direct, House Bill 19-1287 has a section that pertains to improving care coordination throughout our SUD system, and so we're going to be working on that in conjunction with the waiver, but also, that's work that was prompted by that legislation. So we will be putting together an implementation plan, and a lot of the stakeholder work that we're going to be doing come October and on. We expect to have regular meetings looking at those milestones and how we're going to operationalize those milestones with the RAIs and the providers. So you'll please expect to hear a lot more from us as we move further along on those pieces.
And this is Susan. I don't know how much information is available on the website, but that formal implementation plan is a requirement from CMS of our 1115 waiver. And they often do include templates and other information. In fact, I think it might be in the same Medicaid director letter.
Yes, we have a link to all the other documents.
Yeah.
The implementation plan, if you'd like to see the template, the evaluation and monitoring, design protocols, plans are all on there too. And you can, there's links on our stakeholder webpage.
And those are what's called post-implementation deliverables or post-approval.
Yeah.
Post-approval deliverables. So I think the implementation plan is due 90 days post-approval, but certainly
We're well ahead of that.
we're working on it already with an eye towards making sure that we hit that 90-day deadline and perhaps do it faster.
Just checking to see if we have any questions from our online participants. And it doesn't look like that at this time, so back to the room. Do we have any other comments or questions in the room?
Yeah, I've got another question.
Yeah.
I'm JK from the study group, and I found out today that New York submitted a waiver for jail transitions specifically, and you mentioned transition to care being part of this. How, I don't understand the waiver process that well. Is that specifically part of this, or would that be a separate waiver, or is it not a waiver at all? Like, how do you?
Well,
jail transitions?
and it's not written into the waiver application. I think it will come into play when we talk about when the implementation plan. However, you know, I think there's two things. One, there's been a lot of work that we've done to ensure that people transitioning out of incarcerated settings, whether they be jail or prison, do become Medicaid enrolled. So, you know, we're going to continue to you know, sort of rest on or further that work, that attention to that issue, and also think about how do these people get connected to the RAIs, and how do they get their supports for outpatient or whatever level of care it is that they need. So that would be work that we do when we look at that, the care coordination milestone for the implementation plan. Yeah, I was in Larimer County yesterday. They hosted the Rethinking Addiction Conference, and I heard a little bit about their model, and sounds like they are really doing coordinated work with their criminal justice entities, and so I think there are places in the state, and I'd like to hear more throughout the state of how that looks, but where there are good things happening.
And as it relates to specifically criminal justice population, the Support Act, which was passed last year, does require that states suspend eligibility for individuals who are in an incarcerated setting. We have implemented that, so that has definitely helped, I think, with some of that. It's not perfect, I'm sure, but at least we have built the mechanism into our system to track and monitor that. Sometimes it's just that information sharing generally.
Yeah, some counties are perfect at it, and others don't seem to have figured it out. So I don't know what the disparity is.
Into that a bit? Yeah. We're going to be doing some targeted work throughout the state on capacity, and part of that work will be understanding kind of how their systems work and where the gaps are and how the transitions occur. And so I appreciate the comment to have some attention to that issue as well. Daniel, you look like you had a question?
Well, none of them are fully formed in my head.
Okay.
Just a comment for
Do you have any questions from our online participants? No, not at this moment. Back to the room. Any comments or questions?
I may have one that fully formed. So Daniel Darting again. Would it be that the state plan would include some estimate of the penetration rate for residential services amongst Medicaid members? Is that now, as I'm better understanding what this document is and what it isn't, doesn't make sense here so much, but more broadly, right? Because I think about what the estimates were around the outpatient expansion benefit, and I think reality was well past the estimate. I think almost by a little over double. So that's just a general question. You know, wanting to not see that happen, especially for a high cost service like this. I'm just curious about that.
So the question, I think, is around what kind of estimates might be available or might one see on that non-waiver, non-IMD services.
Or just all of it.
Yeah, I mean, certainly, we will build an estimate of the total cost, because we have to manage to the budget that we've been given. The capitation payments will also include any costs that will be covered and affiliated with the capitated components. And then whenever we do a state plan amendment, there's a cover sheet, has a formal OMB number, I don't know what it is, where we have to tell CMS our estimate of what the costs are going to be for that new benefit. And that's for them to plan as well in terms of what any additional costs might be. So we will have to produce that number when we introduce and file our state plan amendment. So there'll be several different ways in which these numbers are being used, but there will ultimately be, we have to manage to the overall budget.
The state plan amendments go through a public notice process as well. Do the estimates?
I know we have to tribal notice. I don't know what's publicly posted.
Yeah.
We can find, I can't remember. We can find out. We have people here on staff to help us.
Yeah.
That.
Total access.
Mm-hmm.
Yes.
Quick look to our online participants. Any questions or any comments from there? It does not look like it, so back to the room.
We could open up the phone lines once again.
Kelly, can we unmute the lines, please?
All guests have been unmuted.
Yeah. If there's anybody on the phone who is interested in giving us a comment or asking a question, please do so now. Okay. And I'm guessing that there's no comment or question on the phone line as well. If you are actually experiencing a technical difficulty with your phone line, please feel free to join the webinar and submit your question or comments that way as well. We are accepting any questions and comments on the chat function. Okay, Kelly, can we mute the phone lines once more and bring it back to the room?
All guests have been muted.
And we are back to the room. Do we have any other comments or questions in the room at this time? Okay. Any other comments from our department staff? John, Susan, Kim?
No, we really appreciate the feedback that you all provided today and invite you to continue to submit comments through the web portal that is available on our website. You have through the remainder of, almost through the entire month of September. So September 27th is the last day to provide comment. And we appreciate all the collaboration that's occurred up to this point. And as I said before, there'll be lots to come with the stakeholder engagement around implementation as we move forward.
Okay, one last quick around the room, and I'm not seeing any comments or questions or hands go up. So I'd just like to reiterate that we are recording today's webinar, and any comments or questions that we received. We'll also do the same at next week's public hearing in Grand Junction. The comments will be incorporated into the demonstration waiver application along with the state responses to said comments or questions, and for the purposes of transparency requirements concerning the federal government's public notice period. Following the webinar today, we will post the recording from the webinar today, as well as the presentation slides that Kim used earlier, on the Ensuring a Full Continuum of SUD Benefits website on the department's homepage. Other than that, thank you very much for joining us on this lovely Friday, and we'll talk to you again soon. Thank you very much.